Yeah, so I'll actually speak about repeated measures of the brain age gap in mood disorders to kind of pinpoint whether we can see whether it's a stable imprint or also a dynamic process. So people with mental disorders tend to age faster and live shorter, and a study showed that mental disorders may reduce the life expectancy for as much as 20 years. But the reasons for this are still poorly understood. So I think really the goal here is if we can identify what drives biological aging in individuals with mental ill health, we may be able to prevent, delay, or halt aging trajectories. Now, in recent years, my work and that of others has shown that people with depression tend to have older appearing brains, as demonstrated using the brain age framework. And there is variability in the methods and the models used to predict brain age, and also the estimated mean differences. But I think there's robust cross-sectional evidence, and it supports the idea that older appearing biology in depression is not only limited to, let's say, functional measures like hand grip strength or molecular markers like telomere length, but also clearly detectable at the brain level. And most consistently, this has been observed in brain structure, although some studies have also found similar patterns in brain function, for example. But whether an older appearing brain is a cause or a consequence of depression, I think is still an open question. We know that many different factors contribute to the brain age gap across the lifespan, and some studies suggest that this gap reflects more of a vulnerability marker linked to early life factors rather than something that is predictive or can track brain changes over time. And in one of our collaborative studies, using data from almost 4,000 participants from the Enigma MDD consortium, we found that a higher brain age gap was associated to increased genetic liability for depression, but also depression-related traits such as higher BMI and higher inflammation levels as indicated by CRP. Early life adversity also played a role, I think interestingly, the most robust and unique associations there were found with modifiable lifestyle factors like BMI and smoking. And this highlights the potential to target lifestyle interventions to support brain health in depression, an approach that is currently potentially underutilized in clinical practice. However, I think it's still important to mention that this is based on cross-sectional evidence. So a key question in this field is whether the brain age gap is dynamic. In other words, can it actually change over time? And could it potentially be used to track treatment outcomes? And of course, there's a lot of interest in this idea, especially because it could make brain age a valuable marker in clinical settings. And I want to highlight two studies that suggest that there might indeed be some dynamic potential. And the first one is from Lay and colleagues back in 2018. And they showed in healthy individuals who took ibuprofen for 8 weeks that they had a reduction in their brain age gap compared to those who were on placebo. And the authors suggest that this may reflect the anti-inflammatory effects of ibuprofen acting on the brain. A very recent study was published showing that individuals with relapsing remitting multiple sclerosis were able to reduce their brain age gap after 6 months of treatment with bexarotene compared to a placebo group. And here, the proposed mechanism behind this effect is remyelination, particularly in the cortical gray matter lesions. But to date, other studies and evidence still remain very sparse. So now, when looking at trials specifically targeted at psychiatric disorders, the current literature is also very limited. And I want to again mention 2 studies. So the first was conducted in individuals with first episode schizophrenia, where the rate of change of the brain age gap did not differ or worsen between responders and non-responders over a 12-week treatment with risperidone. And the second study I want to highlight is one of my own, where we found that the baseline brain age gap did not predict any symptom changes over 12 months in first episode mania youth treated with lithium or quetiapine. And in addition, the brain age gap also remained stable over time and was unaffected by treatment or didn't change following treatment. So I think interestingly, and Christian also mentioned this a little bit, despite the growing research interest in brain age as a framework and the many opportunities I think that are out there to do secondary analyses using existing trials with repeated MRI scans, only a handful of studies have been published so far. And my sense is that the field might be facing a bit of a publication bias here, and maybe null findings are being unpublished or underreported. But I'd like to have that discussion with you as well. Now, given that much of the literature does seem to point to underlying inflammatory pathways, metabolic dysregulations, as contributing mechanisms to the brain age gap, we were very eager to study whether a lifestyle intervention based on running therapy would be able to point to dynamic changes. So we had participant data for the MOTAR study, which is mood treatment with antidepressants or running therapy, which was conducted between 2012 and 2019. And it was a 16-week intervention, and it employed a partially randomized preference design, so participants without a strong treatment preference were randomly assigned to either intervention. Now, the primary analysis of that trial showed that running therapy and antidepressant medication had a very similar effect on mental health. So we had very similar response rates, very similar remission rates. And this really demonstrated that running therapy could be a valuable treatment strategy in mental health care. However, when we looked at physical health, the groups differed significantly on various changes in physical health that were both related to an improvement in the running group. So we saw improvements in, for example, waist circumference, lung function, and heart rate, but also a worsening in the antidepressant group. So higher inflammation as indicated by CRP, poorer heart rate variability, and an increase in weight, so weight gain. So again, I think this lifestyle study was really of particular interest to see whether running therapy might potentially have differential effects on brain age as well. So now when deciding kind of which brain age model to use to obtain predictions, our initial intuition was to go with a deep learning model that has shown very excellent performance accuracy, has been trained on the largest and most diverse assembled training data to date. But I think recent evidence has also shown that there's a bit of a divergence between model performance and clinical utility. So if you look at the left panel, our work in an Enigma MDD consortium showed that in 13 participating cohorts, there was no relationship between model performance and the effect size of the case control difference or the estimated differences in the brain age gap. And then on the right-hand side, you can see that a systematic review published in Patterns also similarly showed that across different studies, model accuracy was not related to model utility. And then model utility here is defined as the absolute correlation between a brain age gap and the studied phenotype of interest. So Basham and colleagues in 2020 also suggested and provided evidence that moderately fitting brain age models actually obtain significantly higher differentiation compared to tightly fitting models. Now, I won't go into the details too much, but I think to put the upcoming findings a bit into context, we must appreciate the features that are being used to train different brain age models. And so on the left-hand side, the first one, the Enigma photon model, is a very simple model based on 77 free surfer-derived measures of thickness, surface area, subcortical volume that we developed within the Enigma MDD consortium. And the second is a convolutional neural network that is trained on voxel-wise patterns without any explicit region-based feature extraction. So it really looks at low-level features, edges, contrasts, textures, mid-level features, shapes, structural boundaries, things like that, and very high-level features as well. And here you can see that, as expected, or what we anticipated, is that the deep learning model outperformed the Enigma photon model, although the simple model also showed good performance accuracy and test-retest reliability of both the brain age as well as the brain age gap. And when comparing cases and controls, the PyMed model estimated the cases appeared about half a year older, with a small non-significant effect of 0.17 cohens D. And in contrast, the Enigma photon model estimated a larger mean difference of 2.5 years between groups, with a moderate effect size of 0.44. Now, going into the primary research question, we conducted a linear mixed model with brain age gap as outcome, and time, treatment, and a time by treatment interaction as predictors, while also correcting for age, sex, and Euler number as an indicator for image quality. And we found that while the regression coefficients of our predictors of interest are very consistent in terms of the direction of effects, the Enigma photon model yielded stronger coefficients. And I think in terms of significance, there was only a trending effect here of the time by treatment interaction in the Enigma photon model and a non-significant interaction term in the PyMed model. So I think when we correlate these brain age gaps from both models while partialing out the effects of age, we can actually see that there's a relatively low correlation between both the brain age gaps generated by the different models. And this suggests, as previous studies have also shown, that it may capture complementary aspects but different aspects of brain age variance. And I think one advantage of this is that what you can then do is integrate them into a combined score. And then by actually integrating both scores, we found stronger effects that better capture or outperforms the treatment impact than the individual scores did, or the individual brain age gap scores did. And as you can see from this plot, where we have the brain age gap on the y-axis, residualized for age, sex, and Euler number, and the two time points before and after treatment on the x-axis, you can see with the spaghettis that there's a lot of individual difference as well in the dynamic change, but I want to draw your attention to a couple of things. So at the start of treatment, both groups don't significantly differ in the brain age gap, and there is generally over time no main effect of treatment. But looking across both groups, the brain age gap does show dynamic change over time. And while individuals in the antidepressant group show an increase in the brain age gap following the 16-week treatment, this effect was not so apparent in the running therapy group. So maybe contrary to the expectation, so if we're talking about dynamic change, it doesn't really seem to be a reversibility or a normalization of brain age following the reduction of mental health or in the running therapy group, but it's more a worsening of the brain age gap in the antidepressant group. And that's also a bit consistent with what we found in the primary study. So this finding, I think, still requires follow-up, but my intuition here is that it's driven by the psychotropic weight gain and the changes in inflammation as seen for CRP. So to conclude, we find brain age gap case control differences consistent with literature, and there is dynamic change following treatment. Running therapy may help halt further progression of poor age-related brain health, and antidepressants, while improving mental health, may have unintended negative effects. So some methodological insights, models with moderate fit may better differentiate the clinical groups. And in using the Enigma photon model, because Euler number or image quality was associated, I would include that as a covariate in downstream analyses. Both brain age models showed consistent effects, but different magnitudes. And combining different brain age models may enhance sensitivity, as shown by integrating multiple brain age gaps for stronger detection. So next steps are heterogeneity, to look into the heterogeneity of symptoms, as Christian also pointed out. And we also have 52-week follow-up data. that we're looking into. And my personal interest is then also to look at the dynamic links between other biological aging indicators. So some challenges, I think one of the first challenges in brain age research is really deciding which model to use. And it's important to realize that a model with a higher prediction accuracy doesn't always mean that it's more clinically useful. And we see here that the models with only a moderate fit showed stronger differentiation. But I think in reality, pragmatic factors or logistic factors often drive the choice of models. So things like what data is available, the computational resources, or access to collaborators that have the specific expertise. So this really shapes what's feasible in most studies, I think. Another concern is selective reporting. I think there's a real risk of testing multiple models, but only reporting or publishing on the significant findings, which will distort our evidence base. And I think even selecting a model is very complicated because the literature is quite fragmented. You can already see at this conference, it's all brain age, but it's EEG, it's resting state, it's functional. It's very different. So I think we really need to, we can't really make direct comparisons, and it highlights the need for more consistent and standardized language. And on top of that, I think gathering code for different methods and finding models that are newly updated, running systematic comparisons really takes time and coordination. So I think we can really learn from, for example, the field of epigenetics, where there are centralized and standardized toolkits that exist that can calculate multiple age clocks. I think I realized that with imaging data, this is a bit more complex, but I think there's clearly a need for at least like something like a centralized repository for brain age models. I'm going a bit over time, I'm sorry. Finally, transparency is very essential. So with growing enthusiasm around brain age research, I think null findings might be underreported. That makes replication efforts and careful interpretation of the results very critical. I'll skip this, but I think having more systematic agreement and disagreement across studies and really looking at meta-analysis and pooled analysis is the way to go here. So this is also a bit of a call for collaboration. So if you have access to data sets with repeated MRI scans of individuals with depression or anxiety disorders, either naturalistic or in the context of an intervention, we are currently planning to do a pooled analysis and are actively looking for collaborators. Finally, this is just a plug to visit a poster of a collaborator. And with that, I would like to invite Majores to the stage. Thank you.